for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I will be discussing some more challenging lupus cases with Professors Ricard Cervera and David Isenberg from the Lupus Academy Steering Committee. Ricard and David, welcome and thank you so much for joining us today. Let's discuss some lupus cases. Ricard, this first case about bone health and vitamin D, and lupus of course, is from your clinic. Let's review the case history. A 60-year-old female, Caucasian female, was diagnosed with systemic lupus erythematosus based on photosensitivity, pleuritis, thrombocytopenia, and detection of antinuclear, anti-dsDNA, and IgG and IgM, anti-beta-2 glycoprotein 1 antibodies. She had required low to moderate doses of prednisolone over 13 years of follow-up, as well as regular oral intake of vitamin D. She was now 73 years old. 1 month before this current admission, she had been hospitalized due to a pneumococcal community-acquired pneumonia. She had also reported 6 days of dorsal back pain, but had no history of trauma. When she was admitted now to Hospital Clinic of Barcelona, she had acute back pain. Her medications on admissions included hydroxychloroquine, 200 milligrams a day, prednisolone, 5 milligrams a day, calcium and vitamin D tablets, and several painkillers. The patient was in a regular state, no outstanding findings on a physical exam, and the back examination revealed a selective point of pain in the dorsal spine. A lateral X-ray of the thoracic spine revealed a reduction in vertebral height, indicative of fracture at the D9 vertebra. Laboratory tests that were made on admission showed a low platelet count, 21,000 platelets. So, Ricard, at this point, what do you believe was the cause of the vertebral fracture?
Thank you. Thank you very much, Raquel, for this nice presentation of the case. Certainly, this was a vertebral fracture, and the main cause that we suspected at this point, due to the long-term use of steroids, was osteoporosis. But several additional conditions we think that it is important to keep into consideration in the differential diagnosis. The patient suffered a few days before, a few weeks before, a severe infection. So the possibility of a vertebral infection could be an option. Also, the patient is an old patient, and we all know that patients with lupus have also a slight increase in the risk of malignancy. So the possibility of a metastasis, a vertebral metastasis, could be another option. And also we have to take into consideration also the option that the patient was with lupus that looks like being in inactivity because of this low platelet count. So maybe some kind of lupus activity, maybe with some vertebral involvement could be a potential option. So, although the main option was really a vertebral fracture due to osteoporosis, let's have the differential diagnosis of these other options.
Thank you so much, David. Do you wish to highlight or have anything at this point?
So, like Ricard, I'm sure I was brought up by teachers who were stressing the importance of keeping the steroid dose as low as possible. And a lot of work has been done by Michel Petri in the United States which would suggest that about 6 milligrams per day is a relatively safe dose and that you won't get many side effects if you keep your patients below that. And my colleagues and I did a review which we published in Rheumatology. Daniela Gellick was the first author, in which we looked at 250 patients that we'd followed for a median of 17 years. 94% of these patients had steroids, 11% of them had fragility fractures. Interestingly, the average dose was about 6.2 milligrams per day. And although there was a trend towards higher prednisolone dose in those who'd fractured, the links were not as clear-cut to steroids as we might have anticipated. But it may be duration, and Ricard is absolutely right. You have to stress the other possibilities. It's not, when you see this, there's a tendency just to assume that it's an osteopenia, osteoporosis, but she's absolutely right. You have to think about these other considerations as well.
Thank you. Ricard, with this patient, besides treating her, of course, acutely with titrated doses of painkillers, which additional diagnostic procedure would you order at this stage and why?
Well, if the main option was osteoporosis, we have to confirm this, and we need the imaging techniques, like, for instance, MRI scans, and also to confirm the osteoporosis by means of densitometry. But in addition, for the other options, we believe one of the options is an infection. We need blood cultures. If also an option is disease activity, we have to confirm by means of biomarkers, for instance, anti-DNA antibodies and complement levels, if there is disease activity.
Okay, and as you sent us, the MRI revealed a fracture at exactly the D9 vertebra. And the bone densitometry, as expected, had a lumbar bone mineral density with a T-score of -2.8, so severe osteoporosis. She had lower than -2.5 and a vertebral fracture. At this point, Ricard, what treatments did you prescribe?
Well, after the confirmation that this was clearly a vertebral fracture due to severe osteoporosis, first immobilization, it's very important. That also is a way to avoid pain, and also to treat the pain that usually is very severe. One option is to use fentanyl patches. But in addition to this, we use at the time bisphosphonate, risendronate, and we try to decrease the dose of steroids, because the main reason of this vertebral fracture was the use of steroids.
There are currently several anabolic and anti-resorptive agents. Some of them are available already, at least in our country, others are not. But none of them are available in European countries, so while worldwide, less even. And even in different countries, they may be not authorized to be taken. It differs from hospital to hospital, at least here, and place to place. So are you able to use at current time? I don't know if when the patients presented you were able or not, but currently, are you able to use teriparatide or romosozumab in Spain to severe osteoporosis?
Yes, at this moment we are able, but this patient was diagnosed several years ago when these drugs were not yet available.
Thank you, David. We are getting more. Yes, please.
No, please, after you.
We are getting more and more aware of higher vertebral fracture risk in SLE patients, as you mentioned and Ricard mentioned, even with normal or mild low T-scores in densitometry. And recommendations have been made to use the TBS, the software to analyze the microarchitecture of bone in the densitometry and treat patients with low TBS score. Do you have access to this technique to screen your lupus patients? How are you doing this?
So it's probably worth saying that the TBS indexer looks at the quality of the bone rather than the quantity, and we only currently have it available for research purposes only. We don't have it available routinely, and we in the UK, as you probably know, have the some would say the good fortune, others would not necessarily agree with that. NICE is a wonderful organization in that it forces the companies to reduce the prices of the drugs that they charged so that we can actually use romosozumab and teriparatide. But NICE has very strict regulations, or well, to be fair, guidelines rather than regulations, but they're guidelines which on the whole we tend to adhere to where we can. And I suspect perhaps like Ricard, we have a very good bone specialist, very interested in the whole issue around treatment of osteoporosis in severe cases, lovely lady called Claire Thornton. We always refer our patients or discuss the patients with her to try to make sure we keep within the guidelines as to what we can afford and what we can't afford. So these drugs are available. They do seem to be a step forward in the management of these patients, but not universally available, unfortunately.
Thank you. Ricard, do you have TBS for densitometry in hospital clinic?
You can use that because we don't have that available.
In our center, we do have TBS for DEXA for the last 1 year and a half, and it really changes the things in younger patients. Ricard, do you have it?
Yes, we have, and this is changing now the way we proceed. But I would like also to stress what David said, that it is very important to work in a multidisciplinary team where we have experts on bone health. This is a full well. So it's very important to have in the team an expert on bone health, on osteoporosis, and these new therapies.
Perfect. Let's go back to the patient. Additional workup revealed that this patient had elevated anti-dsDNA, 30 units for a normal of less than 15, normal complement, C3, C4, CH50, and presence of lupus anticoagulant, and IgG for anticardiolipin antibodies, IgM for anticardiolipin antibodies, and although there was a serum immunofixation revealing an IgG kappa monoclonal band, bone marrow aspiration was normal. So, Ricard, she seems to be on an hematological severe flare with pretty low platelets, 21,000, and serologically she's also active. And you are trying to lower the steroids. So which treatment for SLE did you recommend at this point, and how and why?
Yes, we were in a very complicated situation because we had at the same time a condition that required probably high doses of steroids, and the treatment that probably will give the quicker response. But at the same time, we had this terrible side effect of these steroids. So what we decided is to use another therapeutical option that also is quite quick in producing response, which is intravenous immunoglobulins. So we started with pulse intravenous immunoglobulins at the same time that we start the steroid tapering.
Perfect. And we're supposing it worked. David, I think we all agree this is a challenging case. And before we move on the next case, do you have any further comments or recommendations based on your clinical experience?
I mean, certainly in the latter part of the case, and clearly depends upon the year in which Ricard was faced with this problem, we would certainly have used, in preference, rituximab for these patients because the recoveries of both low hemoglobins and low platelets are remarkably swift with rituximab. And also today with the biologic Me2s, the price is incredibly cheap now. In fact, it's cheaper for us to use 2 shots of rituximab than mycophenolates. It's actually cheaper than mycophenolate now in the UK. So I think we would have gone there. I don't know how it works in Spain and Portugal, but it's actually hard to get hold of intravenous immunoglobulins. We have a committee in the hospital which looks at every single case, and it's quite expensive. So I think in terms of speed and cost, we probably would have gone for rituximab here.
it was an option. Thank you. Let's move to another case. And this time, David, this second case is yours. Let's review the long and complicated case history. A 14-year-old female presents with abundant menses and epistaxis. She had severe microcytic hypochromic anemia. Hemoglobin was 4.9. Thrombocytopenia, the platelets were under 25,000, and with IgG antiplatelets antibodies. She was diagnosed with acute immune thrombocytopenia and treated with 40 milligrams a day of prednisolone. But after 9 months, there was little improvement. Following a splenectomy, her platelets returned to normal. 10 years later, when she was 24, whilst on a trip to southern India, she developed fever up to 40 degrees Celsius, sweats, weight loss, and arthralgia. Upon her return to London, she was assessed for tropical diseases and none were found. However, her fever persisted and she experienced polyarthritis and alopecia. Her labs showed pretty high elevated ESR, so erythrocyte sedimentation rate of more than 100. ANA positive with high titer, anti-RA, anti-LA were also positive, and she was diagnosed with SLE. David, as we know that SLE patients, we do have all of us previously diagnosed with ITP for a couple of years. How frequent is this really on the cohorts?
Okay, so I'll answer that question in just 2 seconds. Just a historical note, because I think some of our listeners will not have known perhaps the fact that in the bad old days, it used to be not particularly uncommon to use splenectomy as a means of treatment in this situation. And actually it was quite good. I would estimate that about 4 to 5 patients out of 6, usually these patients will be given steroids for 6 to 9 months, as this patient was, and if they worked, that was great. If they didn't work, then it was off to the surgeons. From the research point of view, I have to say, slightly selfishly, it was fantastic when this happened, because when you're taking lymphocytes from peripheral blood, you can get a rather finite amount, but when you get a spleen, there are trillions and trillions of lymphocytes. And many of the fusions, the human hybridomas that I made 20, 25 years ago came from the spleens of patients like this one. Those good old days are gone now, unfortunately. So now we're stuck with things like rituximab. So Karpatkin was an American hematologist who did a very good review many years ago and reckoned that about 15% of patients with ITP would subsequently re-emerge as having lupus. And in London, if you develop a fever and you've just been abroad, you will invariably end up in the hospital for tropical diseases. And I traditionally have gone there, and I've only ever made 2 diagnoses there, because by the time I get there, they've had all the tests for tropical diseases and they failed. So either I come in and say, let's do an ANA, and it's positive and it turns out to be lupus, or the ANA is negative and it turns out to be adult onset Still's disease. Those are the only 2 diagnoses I've ever made in this hospital. But this one happened to be a lupus patient.
So, and of course, just a part of our discussion, there's a reason why rheumatology and medical and infections and tropical disease are on the same floor in your hospital.
That's true. But in fact, the hospitals, there are 2, in the UK, there are 2 hospitals for tropical diseases. One's in London and one's up in Liverpool. And the London one is literally just around the corner from our building.
So back to our patient. So she was diagnosed with SLE. She received prednisolone 25 milligrams a day and hydroxychloroquine 400 milligrams a day. The registrar was concerned that at the time of splenectomy, no vaccinations had been offered. So she was given the Haemophilus influenza vaccine.
That's correct. 4
days following the vaccine, she complained of numbness in the feet with burning pain and had bilateral foot drop. The electromyogram reported abnormal motor recruitment with decreased recruitment and rapid firing motor units in weak muscles, which was compatible with Guillain-Barré syndrome. And the CSF was normal. At this point, David, with an ongoing lupus flare, and shortly after vaccination, what would be your main differentials and how would you proceed?
So the dilemma here was this a patient simply suffering from CNS lupus prayer, or could this be Guillain-Barré? And we turned up this one case in the literature who'd been given a vaccination in exactly the circumstances, a patient who should have been vaccinated years before when she had the splenectomy, but wasn't, who clearly had developed Guillain-Barré. So there was a historical precedent for this. And we were umming and ahhing and weighing up the different sort of factors. This patient had a low C3, so that kind of favored the fact that it could have been lupus. She had on the EMG, I think, called an F wave, which apparently favors Guillain-Barré. So we were actually in the process of umming and ahhing. And it was a Thursday morning, and we did our lupus clinic then on Thursday mornings, and I got a call to the ward. This patient had suffered from a convulsion. And in one day, she had 4 convulsions. So I think that sort of convinced us this was going to be a CNS lupus problem rather than a Guillain-Barré problem. And the other problem, of course, is that Guillain-Barré is a motor problem. And this patient was also complaining of some burning pain, which made it more likely to be a motor sensory problem. Again, more likely, more in keeping with the CNS lupus sort of patterns. So in the end, we concluded that's what it was.
And Ricard, I'm going to ask you if you have anything to add, but something is just popping on my mind. That is, how do you feel about vaccinating lupus patients when they are in flare? So do you have comments on that, Ricard?
Yeah, this is a risky situation, certainly, because this can certainly increase this disease activity and probably trigger other more severe problems, including neurological problems. Like probably this was the case. So really, this is a situation that we have to take into consideration, especially now in these days that we are talking a lot on vaccination and recent times on the COVID vaccine. So probably the only situation that we have to be cautious is if the patient is with disease activity, because this probably can increase or trigger additional manifestations, and probably this was the case.
So we're going back to the case, and she was recovering. 3 months later, the patient was doing well. There was no proteinuria, hematuria, a GFR and kidney ultrasound were normal, but she was hypertensive with 16/10. Enalapril was given, which rapidly resolved her hypertension, and prednisone was able to reduce it to 15 milligrams a day. Azathioprine 50 milligrams a day was added. However, 3 months later, so 6 months after the previous flare that you were talking about, she developed an horrendous skin rash involving the whole body, including the scalp, and it looked vasculitic, but with some blistering. David, how did you determine what was the cause of the skin rash? Was it drug-induced? Was it the disease?
So that was the challenge, of course, and you've highlighted the differential diagnosis, really. For us, it was challenging. It was truly one of the worst rashes I've ever seen in a lupus patient. It was whole body. There clearly were some blisters, but there was a vascular base to it. And we had a challenge with the patient's family. The father in particular was quite an aggressive guy, and he demanded a second opinion. I've got to have a second opinion. You guys are not doing a good job. And it was the very early-ish days of the BILAG group, and quite by chance, the following day after I'd been approached by the father, I happened to be hosting a BILAG group meeting. So I said to the father, look, I can do better than a second opinion. I can give you 8 second opinions. So he backed off a little bit, and I got all the original members of the BILAG group to come and look at the patient, and they all agreed, this is very difficult. And they agreed we have to sort of follow both pathways, both to stop the drug, which was the enalapril, but also to do a skin biopsy. And I think clearly that was the right thing to have done, because the biopsy confirmed the presence of the bully, but it also confirmed the presence of the vasculitis, a leukocytoclastic vasculitis. So we felt that this was likely to be a combination, of a rather unfortunate combination, both of a skin flare of the lupus made worse. Now, enalapril rashes are not that common, but again, we had to look this up, and it is actually well described that there can be a curious delay in the onset to the blisters. They came to be, in this case, about 3 months. So it kind of fitted the pattern of a late onset enalapril rash, unfortunately, which coincided with a lupus flare. So we had to sort of adjust the treatment, but that's included stopping the enalapril.
And as you mentioned, one of the differentials for this rash was bullous cutaneous SLE, which is pretty rare. Ricard, do you know how often have you seen it in your cohort?
Very, very, very rare. I personally only remind a couple of patients. I've seen hundreds of patients, and I think that they are recorded as just 0 in the big year lupus cohort. So it's very, 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 very rare situation, but can happen.
So of course, with this patient, David, I wouldn't like to be on your shoes. With this patient, we had now at least 2 flares with other manifestations that are so rare in lupus, but could be comorbidities, but you don't know if it's the other thing or the flare. So challenging. And fortunately, she did well over the next 7 years. But as you told us, she presented again with recurrent fever, nausea, abdominal pain, and diarrhea, lasting a couple of months, and was subsequently admitted to the hospital, where examination revealed fever, not so high, but fever, diffuse abdominal tenderness, and the serology was negative to normal ANA, anti-RAW, anti-dsDNA, ANCA, anti-cardiolipin, lupus, anticoagulant, C3, C4 were all normal. Chest X-ray, echocardiogram, and blood cultures were unremarkable, but she had a cholecystitis and started antibiotics, of course, with cefuroxime. And 2 days later, as you were mentioning before, she had a generalized tonico-clonic seizure, leaving a mild left hemiparesis and brisk left upper limb jerk. So not a clean seizure. It had deficits after the seizure. The CSF was sterile with a slight elevated protein, 0.71, normal glucose, and 2 lymphocytes. The MRI from the brain showed abnormalities consistent with herpes simplex encephalitis, but PSR for the herpes simplex was negative and no oligoclonal bands were found. CRP pretty high, 122 milligrams per liter, and ESR also over 120. She was given IV acyclovir, but she continued deteriorating. So, David, what happened next?
Well, I will back up just a little bit, just to emphasize just how remarkable a case this was. This patient, when she presented originally with what was obviously lupus, had a strongly positive anti-nuclear antibody, a low complement, anti-Rho. She had low levels of phospholipid antibodies as well. And yet when she represented 7 years later, they'd all gone. Everything was serologically was back to normal. So we're now faced with a patient who serologically doesn't have any evidence of lupus, but is having recurrent seizures. She's unconscious by this point. And the MRI scan, I'm sorry you can't show the picture of it, was absolutely remarkable. I'd never seen anything like it, actually. Everything was wildly distorted. The suggestion that it might be herpes simplex encephalitis was just a sort of really what I call an outside guess by the neurologist. And we were absolutely stymied as to what on earth was going on with this patient. So we took a decision which in nearly 40 years, I've only ever taken twice before, and that was to do a brain biopsy. Now, I'm very keen to get Ricard's experience with this, because I've done 3 altogether now, and I have to be honest and to say to you, every single time, each of those 3 cases, what I thought it was going to turn out to be, I got it wrong. Every single time I got it wrong. This one, I thought it was probably going to be a lymphoma. I thought this was probably going to be a cerebral lymphoma. The appearance was so bizarre. And in fact, to be fair, the neurologist agreed with me as well. We did the biopsy, and to our utter astonishment, it turned out to be an isolated cerebral vasculitis confirmed on the biopsy. Vasculitis in the brain. We actually had the proof of it. And we then treated this patient with intravenous cyclophosphamide, and it was remarkable. It was transformative. It actually, within 48 hours, she was awake. And I'm going to make a public confession. A number of years ago, I was asked to write a paper called Cyclophosphamide goodbye to all that. That was my challenge. And I wrote the paper, and I can tell you it's the paper I most regret ever having written, because it was so wrong. Because there are certain situations when cyclophosphamide is a really good drug. I always think of this patient as a great example of that. And within about 3 or 4 months, she was really back to normal. She was back teaching again. It was transformational. But every one of us who thought we knew what she had, we got it wrong.
And do you think that this vasculitis with such an high CRP is attributable to lupus?
In this situation, very hard to say that, although I suppose the corollary to that is to say that, as again, I'm interested in what Ricard's views are. My experience with CNS lupus is that it often doesn't go particularly well with other activity in other parts of the body. Psychosis, perhaps a good example of that. So my experience has been that the CNS aspect of lupus is not associated with high DNA binding, for example, low C3, but there are other factors associated. It's often a bit of an oddball, and I presume that's one of the reasons why the pharma companies are very unkeen to allow patients with major CNS lupus into their drug trials. So we've got this ridiculous, annoying situation. We've had now dozens of drug trials, and in every single case, major CNS lupus is an exclusion criteria. So we don't really know whether a lot of drugs, like even Benlysta, for example, would be helpful in major CNS lupus, because we weren't allowed to use it for those sort of patients. Very frustrating, but I'm very keen to get Ricard's experience.
So Ricard, I think that David just pay you back with a challenging, difficult case. So what do you have to comment on these?
Well, I have to say that certainly CNS manifestations in a patient of lupus is certainly probably the most challenging situation, because we have biopsies as the final diagnostic tool for most of the organs. It's quite easy to perform skin, kidney, liver biopsies, but we always try to avoid a brain biopsy. It's probably the main tool for making the final diagnosis of any disease. And as David stressed, we usually use this tool just mainly for confirming malignancies, lymphomas or other type of malignancies. But in this case, it was essential, because you had a very broad differential diagnosis between infection, viral infection, inflammation, either lupus or vasculitis, but inflammation, or a malignancy, a lymphoma. I think that this was really an option. So you were very brave, and I fully agree that this patient deserved the brain biopsy, and certainly this was the tool that saved the patient.
And Ricard, have you done many brain biopsies in your career? Have you done that?
Very few, maybe 3 or 4 or 5, and mainly because the main suspicion was a malignancy. So we have diagnosed lymphomas, for instance, or other rare types of brain malignancy. But maybe we have probably lost some diagnosis because we don't like to perform a brain biopsy in a lupus patient.
It's really challenging and can have damage and sequelae, and we're having more specific techniques with MRI and spectrometry MRI and the functional MRI. But actually, would it help in this patient in particularly? Probably the biopsy wouldn't. It would be necessary to do it. So thank you so much to Ricard and David for joining me today and sharing your insights on these two quite challenging cases. To our listeners, we hope that these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.